Hello and welcome back to another Invst podcast episode. It's been some time between episodes, as I usually start with, but I'm excited to be back. I've just completed a general surgery term in upper GI, rectal surgery, colorectal surgery, and general surgery, and now moving on to breast surgery. So kind of go through some surgical topics as we go. And in this medical episode, I'm going to be covering colorectal cancer. Now, colorectal cancer is something that impacts about 299 Australians every week. So that's new diagnosis. It's something that, in terms of surgical presentation, colorectal cancer, in terms of surgical treatment, something that I saw quite often on my rotation and thought I would try and synthesize something in an easy or somewhat easy to follow podcast. Just a really nice overview or snapshot of colorectal cancer as best I can. So I usually just go with broad headings. So firstly, what is it? So it's a cancer that begins in the colon or rectum. And 95% of colorectal cancers are adenocarcinomas, so from glandular tissue, right? So if that terminology is unfamiliar, go back and I would recommend looking at, sort of what are your types of cell lineages and what is adenocarcinoma, a bit more detail, but that's what colorectal cancer is. So you can essentially have these cancerous and non-cancerous growths within the lumen of the colon. They can be called polyps, and over time, the polyps can become cancerous. They can change their morphology. So it's important that when we discuss screening and colonoscopies and this morphology of these polyps are really important. So how does it actually present? Before we go into more details of what it is, how is someone going to come to a hospital or GP clinic or wherever, and you sort of have to synthesize or start the workup for this condition? So it can be quite an insidious onset. There could be just constipation, there could be diarrhea, there could be obviously the more frank signs, which is rectal bleeding or blood in the stool, which is something that you want to delve into the history more, like how much blood is there, when did they start to notice the blood, and then I guess the stool type as well, and the Bristol stool chart is something I recommend you looking up as well. It can be helpful. They can also present with just abdominal discomfort, generally feeling unwell, or where they don't feel the bowel empties completely, so they need to go to the bathroom but are unable to actually empty completely. And then you've got more like constitutional symptoms that you should always ask, your fevers, night sweats, weight loss, and then I would say specifically for colorectal cancer, sort of anemia-based symptoms, that fatigue, that sort of shortness of breath, maybe even as well, symptoms like that. So they're sort of some of the ways that it could present. Hopefully I haven't missed any big ones there. Yeah, that'd be the key ones. But in saying that, it may not present with some clinical features, because with actually how this occurs, which is my next sort of broad topic, is there's a major genetic component of that. So what I've seen when I've done general practice placements is that people have known that, hey, it's in my family, we've got colorectal cancer in our family, or we've got a gene mutation that we know of in there. So I think it's best to discuss those now, of like, what are your risk factors for colorectal cancer? So familial adenomatous, I hope to pronounce that properly, polyposis syndrome is something that, positive family history, there is quite a high incidence or likelihood that cancer could present, as well as hereditary non-polyposis colorectal cancer as well. They're the key hereditary syndromes that we know about. Additionally, there's other conditions as well, like inflammatory bowel disease, that can increase risk factors as well. And then you've got that they're kind of non-modifiable genetic factors. You've got some more modifiable ones, such as smoking, alcohol consumption, obesity. One that's, I know it's slightly contentious with some people, but broadly I know it's accepted, and a lot of literature is red meat consumption, and then a high fat and low fiber diet as well is a risk factor. Upon my reading, I had sort of noted it down, is that certain bacteria as well in the gut can also impact colorectal cancer, or increase the risk as well. Additionally, there's actually protective factors as well, which is important to discuss. And I used to always it really stood out to me that sort of lifetime aspirin use and that NSAID use and other NSAIDs can actually be protective against colorectal cancer as well. But just going into the actual sort of, I guess, pathophysiology or how things can, I always have this imprint from my mind from med school is the two pathways or the carcinogenesis. So how does the carcinoma actually come to fruition? And there's two main pathways. And the first pathway is the most common. I think up to 85% of cases is chromosomal instability pathway, where you've got this adenocarcinoma, is an accumulation of oncogenes. So the mutation in oncogenes, one of them, the main ones being KRAS, and then you've got those oncogenes, and then you've got tumor suppressor genes that also aren't or are mutated, which is APC and T53. And this causes a transformation in the cell lineage to go into those adenocarcinomas and then into carcinomas, which ultimately creates invasive tissue. So, and then that's the first pathway. If you imagine sort of a fork in the road, the second pathway is micro satellite instability pathway. So this is due to methylations or mutations in mismatch repair genes. So obviously those repair genes have a role in making sure the cells that are not going through the correct lineage are perhaps methylated. So, but there's mutations in that. So they're the genes that are impacted there. Additionally, there is also to suggest that COX-2 overexpression, so cyclooxygenase overexpression is associated with colorectal cancer. That's why some of those NSAIDs and aspirin play a role. I thought I'd just link that in there. Now, so how do we actually investigate it? So we've sort of spoken about what it is, what people may present with, or they may know they're at risk of it. And additionally, people may also have these genetic mutations that we don't know yet, but we were sort of worried about them. So the first thing you want to do is your physical examination. So a good gastrointestinal examination. I would follow your university's OSCE structure, or if you're, I don't know, there's people probably watching this from various different levels, whatever, your preferred examination technique is, and then always trying to do a rectal examination. So looking at the back passage and making sure if there is any blood on the finger when examining, or any palpable lumps as well will be part of it. So yeah, and I remember reading, I always thought to myself, a rectal examination, probably very uncomfortable. Is it going to be positive all the time? Well, distal rectal cancers can be palpable. So you want to make sure that, you're sort of ruling that out early as well with that examination. And then you've got something that I know that with risk factors, you can have a scope, so a gastroscopy and a colonoscopy. Sorry, I should say colonoscopy in this case. I always say scopes in general, but let's be more specific. Colonoscopy here can be done in all patients with suspected colorectal cancer. So that you can actually look at the morphology of some of the polyps or growths, or visualize any bleeding as well. I know that in our unit as well, I saw contrast barium swallows. I saw a lot of fluoro swallows and things like that used, and one of them is because you can see narrowing of bowel due to stenosing, or if there's a mass, you can see the narrowing of the lumen. So I saw that used as well, which was interesting. And then on your bloods, after you've done some of those techniques, you can look at your tumor markers. CEA is the main one, I believe, in colorectal cancer. I'm probably not going to go into staging, because I know that is important. That's probably a podcast in its own. How do you stage these cancers? I just want to give people sort of a broad overview of what to do with the investigations. But obviously, when you're looking at management, which I'm going to talk to now, which I'll just talk over the broad concepts, a really important part is going to be staging of the tumor, having the histology, having the I guess the morphology, the some of those genetic testing perhaps as well will play a role in that. It's not actually going to play a role in staging, but in terms of prognosis as well. And then your findings on colonoscopy as well is going to play a role in perhaps tailoring certain managements or management regime to the individual. But broadly, let's talk about first what I've seen, which is surgery for colorectal cancer. So there was some pretty interesting surgeries, and mainly being resections. I saw where you got resectable metastases if they're spread to local, lymph tissue, lymph node dissections, or removal of the primary tumor is what you can. There's also palliative surgeries as well that I saw offered. But then you can look at systemic therapy, so that's your chemotherapy regimes, but also there's some trials in biologics as well, and then radiation therapy. But that can have obviously some prominent side effects, so it would need to be sort of, specifically looked at. Now, those surgeries, what did I see? And I guess what could I speak to is colectomies, and hemicolectomies are something that I saw often, or sigmoid colectomies. And then you've also got subtotal and total. So that could be a resection of most of the entire colon, or you've got, the hemicolectomies that is just a part of the, say, distal ileum, or the ossicle valve, or the cecum. Like, there's certain parts that can be resected and rejoined, and there's different approaches for those. But that's something that I got to, fortunately enough, I got to see. So they're probably the key management options when we look at an overview of that. So I guess to recap, what are the key points? Just knowing it's quite common. I sort of looked up the stats. It was like 299 people a week are diagnosed with it. There's a large genetic component, family history component to it. Obviously, there's modifiable risk factors and protective factors as well. There's important pathophysiological findings in where the cell lineage can go to an adenocarcinoma. And in terms of your diagnostic pathway, having that structure and thinking about what would the findings be on a rectal examination, what would you find on a colonoscopy, what tumor markers can I have, or what can I order and then follow up with, and what does that mean prognostically, and then what are the actual surgical versus chemo and radiotherapy options. So hopefully that was an okay overview. It's good to be back. I always try and keep them short and sharp for the purposes of people just, getting a little bit of a recap and a refresh. So hopefully that will be helpful, and I'm looking forward to the next episode.